Welcome. In this video, we're going to start anatomy of the eye. Specifically in this particular section, we're going to talk about the bones of the eye. So let's go ahead and move along to look at our skull again. And not everything on this slide is anything you need to know. In fact, we're just kind of circling in and getting ourselves to the point where we can look at this area right in here. But I wanted to give you a side view as we then look at the front view. And again, we're going to look and focus in on these areas known as the orbit of the eye, because these are the bones that compose and protect the eye. Some of them are part of the neurocranium because they also connect and protect the brain, but these all are relative to surrounding the eyeball. That's what we're going to talk about. So let's go ahead and zoom in. And to begin with, if you follow along on your handout, you'll notice we have the frontal bone up here at the top. I guess I should pick something that stands out a little better, so that yellow probably, or maybe you'll go with red. We have the frontal bone, which is going to be the roof portion or superior portion of the eye wall, and actually makes part, if you look down here, part of the medial thing. So in the back of the orbit, in the posterior portion of the orbit, it also forms part of a wall. You have the sphenoid bone, which is this wing-shaped bone right here. It has two, the lesser and the greater half. So I'll put an S here and an S there. And this forms that posterior portion of it. This is also where the optic canal, where your eye, the optic nerve comes through and passes through. Next to that, we have the ethmoid bone. And so, by the way, the sphenoid bone forms part of the posterior wall of the eye orbit. We have the ethmoid bone, which is right here. And this, again, forms part of the medial wall and the posterior wall of the orbit. And it is probably one of the thinnest bones that we have there. So it's particularly prone if you ended up with a really nasty sinus infection of eroding there. And if the problem is if the bacteria erode through there, they're into the brain area. All right. The lacrimal bone we have right here, and I'll put an L on it. And you'll notice right there we have this big lacrimal fossa. This is because that lacrimal duct is what kind of sits there. So you have the lacrimal sac and the lacrimal duct that collect the tears and then channel them down into the nasal cavity for disposal. You have the maxillary bone, which I'll put in blue right here, the maxillary bone. This is also part of the maxilla there. So it forms part of the the anterior portion of the eye orbit. It also provides the posterior portion of the, not posterior, I'm going to scratch that posterior and say the inferior. So inferior bottom, think of the floor, and the front of the eye orbit. Importantly for this, the maxilla, in addition to that, if somebody has blunt force trauma to the eye or the eye surrounding structures, this can sometimes fracture and you can end up with the eyeball itself gets squished and has its insides beginning to leak out. They can drain into that maxillary sinus area. I know, really great image there. We also have a tiny bone back there, the palatine bone, that's in green. I'm not even going to try to write on it. I'll just circle there for you. Don't worry about it. I'm not going to be picking up at it. The last one we want to look at is the zygomatic bone. That's over here in purple. And again, it forms the part of the anterior portion of the eye orbit and also the lateral wall. So it's going to provide side protection for your eyeball. And it's also going to be part of what helps protect the front of your eyeball. And with that, we're done with this part of bones. Welcome. In this video, we're going to continue our study of the anatomy of the eye. Specifically, we're going to be looking at the anatomy of the eyelids. Probably not something you've given a lot of thought to, but let's go ahead and head that direction. The give our eyelids a consideration. So as we look at the eyelids, they first have to define what are their functions. We have 3 functions for them. The first is to protect the eyes from injury. So keeping physically things out of the eyes is important. The second is that they should help protect the eyes from getting too much light. So think about a bright light when you're squint. That's your eyelids trying to help keep and control the amount of light that enters through the pupil and in the back of the retina. The third function that the eyelids do for us is to provide moisturization to the cornea by spreading the tears out evenly across the surface as we blink. Now, as we look at it, we think about the eyelids. We'll start out from the outside, moving our way in. We have a thin area of skin on the outside or the interior surface. This skin is really thin, and why it's important to us as a pharmacist is this is the reason we do not want to use high potency steroids around or on the eyes, because they can thin the skin so much that it actually tears or atrophies and sloughs off a bit. All right, the other side that we're looking at would be the mucous membrane. So those I'm going to kind of come over here with a blue marker, and that'll be the part that faces the eyeball itself. So skin on the outside, mucous membrane on the inside, and that these form what we call the palpebral conjunctiva. So the conjunctiva itself, that's the mucous membrane on the eyelid, so this section right in here, is the palpebral conjunctiva, palpebral being the medical term for eyelid. So get that familiar, because we're going to talk a lot about palpebra today. That then reflects back on and becomes the bulbar conjunctiva. So over on this side, the eyeball or bulb would be the bulbar conjunctiva. And when we talk about a reflection, we talk about this little corner right in here. So right there where I'm really highlighting, I want you to note that that's there. That is the fornices. That's the superior one, and we have an inferior one down here at the bottom. This is why when you put your contact in the morning, you don't ever have to worry about it actually slipping back in behind the eyeball itself, because the eyeball actually doesn't connect to it. You have this nice little, you can think of it almost like a bag, where the inside of the bag on one side then reflects back or comes or is attached to the part that's on the outside where the eyelid. All right. So moving along, this slide, when we're looking at the bicularis oculi, if we zoom in a little bit more, again, we have our in this case, the palpebral conjunctiva over here. We have our skin on this side with the red, and in green, I'm going to draw a little bit of here, this connective tissue that's there. That's our tarsal plate. So it's a dense band of connective tissue, and it kind of provides an anchor for the muscles to attach to, and the skin and the other mucous membranes to attach to. It also adds strength to the eyelid, so it's not just a bunch of weak skin and mucous membranes. It actually has this tough connective tissue that helps it out. The superior tarsus, which is what we happen to be looking at, or the one on top, the top eyelid, is attached to the levator palpebrae superius, and that's important because that muscle actually is what we use to open our eyes. The bottom eyelid, as we'll talk about a little later, doesn't have a muscle that opens it. That's just gravity doing it. But here we have to have the levator, which does what it says, levitates, and then palpebra being eyelid. All right, speaking of muscles, let's go ahead and talk about our muscles. This one here, and when we're looking at this levator palpebrae, this one, as I mentioned already, raises the eyelid, and it's under the control of cranial nerve 3, which is the ocular motor nerve. So ocular motor nerve, the ocular motor nerve is going to come in again importantly because it does a number of other movements of the eye. Not all of them, but it does a majority of movements of the eye. So one of the things it does is open your eyelid as we go along. All right. So we just saw the levator prolibri. I also want to point out the orbicularis oculi, and it has two parts. We learned this last time when we talked about the head, ears, nose, and throat anatomy as one of the facial muscles. So it means it's innervated by cranial nerve 7. We're all right, 7 here. So both of that, either way, but that's what it does, is it's innervated by cranial nerve 7. It has two parts. You have the outer portion, which is the orbital part, and the palpebral portion. And you see those already labeled, so I'm not going to draw on it. But the orbital part is when you really tightly squint, what closes your eyelid, and the palpebral part it's smaller and weaker, so it will gently close your eyelid. But both of them work. The contraction of them causes the eyelid to close. Flip that around and go back to our. Moving along, let's talk about one last thing. Here's your levator prolibri again, just a front view of it, and you can kind of see that contraction of it will raise our eyelid. And the last thing I wanted to mention here is our eyelashes. So we see them right here, and I'll go ahead and highlight them in red just so we can make it stand out a little bit. But these are also known as cilia or hairs, and they're located on the margin or the edge of the eyelid. They also have sebaceous glands associated with the eyelashes. And those sebaceous glands can sometimes get infected, and when that happens, we call it a stye. So you have a little bit of that information on that. The eyelashes also have an important function in that they help keep larger pieces of material out of the eye by providing a little of, you can almost think of it like a tent awning that helps protect the eye from any bigger dust particles flying into it as we go along. All right, that ends this lecture, and we'll move to the next one. Welcome. In this section of the anatomy of the eye, we're going to be focusing on the contents of the orbit, and specifically those structures lying around the eyeball, but not necessarily the eyeball itself. So as we move ahead, we'll see first the eyeball, and I'll pull up a little thing to kind of mark it in blue so it stands out. That's the eyeball. We're going to spend more extensive time talking about it and what's inside it and the different layers subsequently. What we do want to start out with is talking about the other information or other structures that are here in the orbit of the eye. We have first off the optic nerve, which I'm highlighting right now in blue so you can kind of see it. So this optic nerve, this is the one cranial nerve that is actually able to be visualized. So if I were to look through my patient's pupil right here, I could visualize the very back of the eyeball, the optic disc, which is the ending or where the optic nerve now enters the eyeball and provides a source for the retina to send vision signals back to the eye. The other thing we have in here are some of the extraocular muscles. So we see a couple of them here. We'll talk about it later, the superior rectus and inferior rectus, and they're a total of 6, but those muscles help move the eyeball around itself. And they are innervated by different cranial nerves. We'll cover that in a later section. But just know they're part of that also. Not shown in here as much detail, but you do have, I'll draw in a little red to kind of illustrate, we've got to provide blood supply to, and we got to have veins coming away from the eye. So you have an optic artery and optic vein supplying the retina with blood supply. Finally, you have this area here, and I'll go ahead and go back in green. All this fluffy, yellowish looking items, that's fat. And the fat in the content on our eye has a job of filling up any extra empty space and also working as a shock absorber so that this very exquisite structure that is the eyeball doesn't take any unnecessary damage, that it stays from bouncing around and doing itself damage. All right. So now we move in and we're going to look at a couple of other things, and I'll switch to blue. We have up in the corner and lateral corner of the eye, up in the top, the lacrimal gland. So LG. And this is responsible for forming my tears. So I'll put a few tears. And notice I'm kind of tracing them away over the direction because that's the way the flow is going to be across the eye. The tears flow across it and then exit into the lacrimal carbuncles and the little lacrimal ducts. They end up in the lacrimal sac, which is part of the nasolacrimal duct. So why are we talking about that? Well, there are a couple things. One, tears are really important. They help keep our cornea moisturized and keep it from drying out. Two, they also help wash away any dirt and debris from the eye and keep that safe and keep the cornea from being scratched up. And thirdly, they provide actually antimicrobial properties. So they have enzymes in them like lysozyme that help lyse or kill various bacteria that could become infectious. So tears are really important. And then they exit right here in this area and then flow down into our nose. This is why when we go and see a sad movie and we get teary-eyed, our nose starts to run because it drains here. Why this is important to us as pharmacists, again, is we will oftentimes give a medication like an eye drop for glaucoma in here. And I want to keep it inside the eye where it can get absorbed into my eye as much as possible. And I don't really want to have it enter the bloodstream other ways. So one of the things I can do is apply nasolacrimal occlusion by pressing here in the medial corner of my eye gently. I can kind of not crush, but close those ducts, and the tears stay, and the medicine will stay in place. It has the advantage of helping the medicine get absorbed into the eye, and it also prevents the medicine from running down here into my nose, which then drains in the back of my throat, which goes down to the stomach, which then gets the systemic absorption. So all that was why it was important that you know about that section of the eye so you can properly counsel patients. All right, this is yet another view. So again, we're looking here, pull it out the green to highlight this time. There's our lacrimal gland making the tears. The tears are going to bathe across the eyeball itself and exit into these lacrimal caniculi, that's the little openings, then into the lacrimal sac, which then drains into the nose and back down the throat, ultimately. All right, we'll move on to our next section. Welcome. In this section, we're going to look at the anatomy of the eye, specifically in situ, which is Latin for as you see it. So moving in, we're going to look at our eye. So we're looking at somebody's eye. In this case, this is a patient's right eye. And the first thing we want to notice is the pupil. So this is the black area in the center of the eye, which is actually the absence of anything. It's an opening in the iris that allows light to travel through. So it is controlled by the sympathetic and parasympathetic system to open up and close more. And we'll talk about this a little later in the actual eyeball when we talk about the structures of the eyeball themselves. We're just looking from the outside. Surrounding that, we have the iris. So in that area there, it's colored blue, is the iris. This is a spot that allows it to change shape and size to, again, allow the constriction or dilation of the pupil. Now, when we look at somebody's eye pupil size, it can be harder to determine in individuals that have a dark brown iris because it's harder to tell the dark brown from the black, but you still can see that with proper lighting. As we move there, we have also, we really can't see it here, but under the area of the pupil and the iris is the cornea. So inside the C, if we were looking at it from the side, we would be able to see kind of a clear tissue. We'll talk more about this, but these are specialized cells that are designed to let light through. and it lets light through to the iris, and more importantly through the pupil, through the lens, to get to the back of the retina and be focused. Where the cornea and the sclera meet, so where the iris and the white meet, we have the corneal sclera junction, which is roughly about that spot. You can't see it again from here, but that's there. And then the white of the eye is the sclera. Now you'll notice that it is not completely white. In fact, it has some blood vessels there, but they do not appear to be abnormally dilated. They're not showing red eye or hyperemia. In most individuals' eyes, it will be a fairly white to slightly off-white color. Some individuals, especially those who have darker pigmented skin, may have slightly darker scleras also. Many times people will inadvertently confuse this with icterus, in other words, jaundice, thinking it's yellow, but it's really what they might refer to as muddy sclera, and it's just a little more hyperpigmented in individuals that have darker complexions. All right, other parts we have here is, and by the way, that's not 100% of the time. You just may see this in some individuals there. Last we have the, or next to last we have the canthus, which are the corners of the eye. And if we were to look specifically at this fleshy part in the medial canthus, we would have the lacrimal caruncle. This is where the tears drain, as we talked about in the previous section. All right, that takes us over to the next spot, the eyeball itself. Welcome. In this video, we're going to be looking at the structure of the eyeball itself. So as we move in, pull out our drawing tools, go with green so it shows up a little bit. The first thing we need to look at is, as you look at this, you'll see it looks almost like a nice round ball. It's very spherical, which is what we'd expect. Changes in that, making it a little squattier or longer, can, however, result in being farsighted or nearsighted. Now, as we look from this, we're also going to see that there are going to be 3 layers, and we see those illustrated here. We have the cornea and sclera on the outside, then we have the vascular layer known as the uvea shown here. So this would be out here, the cornea and sclera, depending on if you were talking about the clear part or the white of the eye, cornea being clear, white being sclera. And then we have the uvea over here in the vascular layer, and then the most inner layer, which I'll put in here, is the retina. And so we'll talk about each of those layers now as we go through here. On the outermost layer, the cornea is a transparent fibrous tissue, so it's still strong, but it's not as strong as the sclera, and it covers the anterior or the front 1/6 of the eyeball. So kind of looking here, everything around here in this little circle that I just drew and above would be cornea. And this is why we say we can look at it from the side. You can't really see it head on, but if you look from the side of the patient, you can actually glance through the cornea to see it's clear. Now, those corneal epithelial cells actually live in a sort of a moment of dehydration. They're not fully dehydrated. We've got the tear glands producing tears that'll keep them hydrated, but they're not as hydrated as they could be. When they do get really hydrated, then instead of being clear, they turn cloudy. So if you have a cloudy, what looks like cataracts, you have to also check to make sure it's not the cornea getting clear or cloudy. That cornea edema could be what's causing it to be cloudy. And that could be brought on by things such as acute angle closure glaucoma. All right, the back 5/6 of the eyeball, though, is covered. We really don't see it here, but it's covered by the white fibrous tough tissue called the sclera. And this helps provide the eyeball with its shape. It also is an anchor point for the muscles, which we don't see here, but we will on later slides, for them to attach to the eyeball and move it around and allow it to change its position. The inner layer, the uvea that we talked about in the middle, is got the iris as part of it technically, and then that iris is a set of sphincter muscles and dilator muscles, so they're aligned so that they could be radial and I'll switch over here to yellow so we can kind of see. You can have concentric circles like this, which would be sphincter muscles, and then you also have muscles, the dilator muscles, that are more like spokes. The dilator muscles, when they contract, will pull the eyelid or the iris open, allowing the pupil to enlarge and let more light in. The sphincter muscles, which are under parasympathetic control, when they contract or constrict, it constricts the pupil and controls less, it makes it less light entering to the back of the retina. And you see that listed on your handout. We talk about the sphincter pupae. That's under parasympathetic control. It's going to make for more acute vision, whereas dilator pupae is under sympathetic control, and contraction of those muscles dilates it. And the way I always think about this is the fight or flight reflex. If I see a lion coming charging at me, I don't really care to count how many hairs are on its mane, or if it has a little puff on its tail or not. I'm just worried about big killing machine of animal coming my direction and a blur, so my pupils will dilate. I'll open up my iris and make my pupil larger so I can get as much light in about it, and I don't care about details, but I just want to kind of see movement at that point. All right, now over here also we have, and I'll draw it in blue, want to point out the ciliary body and process. These are responsible for making the aqueous humor, and they also, the ciliary muscles will cause the lens, which is, I'm highlighting in blue right here, or circling in blue, to change shape. So if the ciliary muscles contract and bunch up, then it allows that lens to round out for more up close near vision. When they relax, then it basically pulls the lens flatter for distance vision. All right. The other part we see here is back in the back, and I'll go back to this where we were looking here. This is a choroid, and its job is to absorb a lot of light. It's a reddish-brown membrane between the pupil and the retina, and what we don't want is to have a lot of light bouncing around in the eye itself, because then it could fire off the retina where we do have vision points and make it harder to see. So we want to absorb some of that light. Think about it this way. When you will go to see the movie, you want to have the screen bright. You don't want the rest of the theater to be bright, because then it'll be harder to see. Same principle kind of here. We're darkening those walls so they absorb the light and don't distract us. All right. Finally, we have the retina itself. Oh, and by the way, the choroid, because it's got blood supplies, it's got the red reflex. In other words, when we see red eye on a camera, that's because we're reflecting and catching the color of the blood going through there. So we call that the red reflex. The retina forms two different parts. We have the optic part, which is in the back, and that's where we have our highest vision points, and we'll talk more about that as we go along. And then we have a non-visual point, which covers the ciliary body and part of the process. These are the areas where we wouldn't have any ability to absorb light and transmit that to motion or sound, visual information. The back of the retina and that area is all known as the fundus. So Fundus. All right, moving to the next slide. This will help us look at a little better part of the fundus. So the posterior portion of the eye, or the back of the eyeball, is what we see with an ophthalmoscope. And we'll see some examples of what you would see with that. As we look there, we have the optic disc right in this area here. And that optic disc is where the optic nerve emerges into the retina. It actually forms our blind spot. So you have no rods or cones over this optic disc. You can't see anything from it. It's located just medial or towards the nose side. So our nose would be over here. Imagine that's being my nose. That part of the eye. Then, as we look a little to the left of it on the screen, we'll notice the little dip here. This is a macula. The macula lutea is located directly posterior to in other words, directly behind the lens, so that the light falls that we want most sharp on it. This is specialized for acute vision. So we have a lot of cone receptors here. Inside that macula, and this is, by the way, where we get the term macular degeneration. So if you have loss of this area of the macula, you lose your acute vision, your ability to see things in the center of your vision that would be responsible for you reading the slides or reading the note handout. But inside that is the fovea centralis, and that's that little dip here that you have. So I'll actually also do that in blue. And that's in the center of the macula. It's only about 1.5 millimeters wide, but it has the highest concentration receptors. So why this is important is this gives us our sharpest vision. It's also the most sensitive to light. So when you're inspecting an patient's eye using an ophthalmoscope, you want to look at the fovea last because it's going to be the most difficult for the patient to tolerate. All right. Otherwise, when we look in here, we'll have some central arteries, and we're going to, this one we really didn't see any arteries or anything like that we could see. But here along, so this is an example of the back of the eye. We didn't, on this, we're looking at and our arteries are going to be the bright lines, but they're narrow. So this one right here is an artery. The veins are going to be wider, and they're going to be darker. So the blood returning is a little darker because it's deoxygenated. The arteries, when you actually look at them, look like they have a little bit of shine, almost look like they're under more pressure because they are under more pressure in that case. Now, if we're looking here, I also want to point out, if you go over here, notice how these guys, the arteries and veins do kind of all reach out to and around the eye, except for this spot here, which I'll and this area is the macula in this center spot, and then inside that is the fovea centralis. Why are there no blood vessels feeding this particular area? Because where you have blood vessels, you can't have rods and cones. Now, we'll see a little bit later on about the veins. When a vein crosses an artery, we want to look like down here. We'll look at that and see. I don't see anything being eaten out of one or the other in this particular one. So this does not show any signs of AV nicking. But when we do see an artery pressing in and kind of taking a bite out of, or making it look like a bite's been taken out of a vein, we call that AV nicking. Show you on this one, when we do find, let's say we were over here and we found this artery, or this happens to be a vein, what I would do is, as I'm looking for that, I would follow it back with my ophthalmoscope to the source until I can find the optic disc. And then that's where I visualize, look at what I see in the optic disc. I note the cup, and we'll talk about that later. The cup should be at least smaller than half the size of the optic disc. It's a little indention within the optic disc where the nerve emerges. If that cup begins to enlarge, that could be a sign that the optic nerve is actually breaking down on us. So all those have important things. If you hear the term papilledema, which we'll talk about in a later lecture, but papilledema, that means that the optic disc is beginning to swell and break down the cup, and we're having some damage to the optic nerve. All right. All right, again, this just kind of re-illustrates what we're looking at here. Notice over there we really didn't see a lot in those arteries and veins because they're going to be spattered like a tree branches coming over different areas. Real quick. And here you begin to get a little more pattern. If we looked at it, this is as if we cut the eyeball away. Here's your fovea centralis, right over in here. And then your optic disc where the arteries and veins all emerge from. And this is another thing I'll jump back. The last thing we want to mention here is, as we go through this, I want to talk about these three different spaces we have in the front of the eye, and I'll do this in green. This in front of the lens, we have the anterior chamber, or AC. This is a space between the cornea and the iris. And this is important because This is where the fluid gets secreted out of the ciliary body and process, and if actually exit the front of the eye, then what we call either through the trabecular meshwork or in the uveal scleral outflow. Don't worry about either of those just yet. We'll talk about them more, but know that that's in the anterior chamber. That's the part closest to what you can see. Behind that is actually the posterior chamber. And I'll circle that in red just to be consistent with our thing. I didn't do the anterior chamber in blue. I apologize, but you get the idea. And the posterior chamber lies behind, so PC. This lies behind the lens or iris, but in between the lens and the ciliary body. This is the ciliary body responsible for the aqueous humor formation, or the creation and secretion of the aqueous humor. And then the aqueous humor flows out in an arrow and kind of comes out this way or exits out this way and out of the body. The last thing we have, and I'll actually do this one in blue since I've been messing up the thing totally, is our post-remal or posterior segment of the eyeball. This is sometimes known as the vitreous chamber. This is jelly-like, so the substance that's in here is more like a jelly. It's really thick, and it's not something... what happens in glaucoma is when we end up with increased pressure in the anterior chamber, it presses back on the lens, and eventually that pressure comes back to the retina. So everything's connected, even though the damage and stuff may be happening up here, it eventually comes back and has damage on the optic disc back there. All right. The important part about this vitreous body or vitreous chamber, and I'll put VB for vitreous body, is because it's jelly-like and everything, it helps keep the lens in place, and we want to kind of keep that in place, and it also helps give the eye its shape from the inside pressing out, and supports the retina on where it's supposed to be. All right, and then this just gives you again a look in the back of the eye. So I'll let you stare at this for a little bit and see, can you identify the different parts? We'll talk later in the lecture when we find some exam findings to show you different types of AV nicking, hemorrhages, and other things. But this is an example of a fairly normal fundoscopic exam. Realize you're not going to see one of these in class because we don't have the ability to dilate the eye to make it this nice and easy to see. Nope, and there we go with our colors. So you can use that part. Welcome. In our final segment, we're going to be talking about the anatomy of the eye as it applies to the extraocular muscles. These are the muscles that attach to the eyeball itself and allow it to move around so that you can look to your left, look to your right, up, down, and even cross your eyes. So, as we orient ourselves, the first thing we need to talk about is, as I talk about some of the things, in whether it elevates or depresses, realize that we are talking about the pupil itself. So everything in terms of movement, you can kind of look at and gauge by relative, what's the pupil doing? If the pupil moves up, then it's elevating. If it's moving down, it's depressing. All right, so we have our 6 muscles. We have a couple slides to this one. We have our different muscles. Let's start with the lateral rectus muscle, the medial rectus muscle, and when we talk about rectus muscles, and I'll write this in blue, when you see rectus, think pulls straight. So that's a pull straight. There's nothing indirect about it. It's kind of a direct eye pull, and it turns this way. So rectus is direct. That's opposed to our obliques. So we have 2 ones that are obliques. Oops, that spelled right. Oblique. And they're indirect because we have to change the way the motion is pulling, and so it pulls the eye in an opposite area. Okay, so our lateral rectus muscle, LR, over here, is attached to the lateral side or the outside of the eyeball, and it turns the eye out or abducts it when you pull on it. It happens to be innervated by cranial nerve 4. And should go, before I get into that too much, let's talk about some of the movement as we mentioned the thing. And I don't know why my pupil got all of a sudden square, but you have elevation is moving the pupil up, depression is moving the pupil down. If you're moving it towards the nose, so 2, that's adduction, AD, adduction. If you're moving away from, that's to abduct. So think about, somebody who's being kidnapped is abducted. It's taken away from. So abduction. And those are the terms we're going to see more and more, not just in the eye, but when we get to talking about movements of the limbs, like your arms and legs, things along those lines, we'll discuss that way. The other part we have to do is talk about intorsion and extorsion. Intorsion means moving the top of the pupil towards the nose, and that would be in. And extorsion would be moving it away, the top of the pupil away from the nose, so it's twisting, and that's X. All right. So heading back into our different ones here, and I'll actually jump, or sorry, not cranial nerve 4, cranial nerve 6. So scratch that. We're going to say cranial nerve 6. And the way I always remember the cranial nerve 6 is an anatomist, or guy who taught me anatomy, pointed out the Lone Ranger, the LR, he was famous for carrying his 6-shooters. So LR6, you and many medical doctors and others have now learned that little mnemonic that makes silly, but it helps. What they did before the Lone Ranger, I don't know. But now you can remember LR6 for lateral rectus 6. Since it abducts the eyeball, that is the abducens nerve. All right. We have our medial rectus muscle, and that's over here in the middle. It is going to be moving the eye medially or adducting it towards the midline. It's innervated by cranial nerve 3. So the lateral rectus and medial rectus are a paired set of muscles, but they're innervated by different nerves. So cranial nerve 3 is the ocular motor nerve. In other words, the nerve that is responsible for most of the eyeball movements. And you'll see on here that 4 out of the 6 extraocular muscles are innervated by the ocular motor nerve. All right. The superior rectus, and this attaches to the top of the eyeball, and it pulls and elevates the pupil up. It also may have a slight adduction, or moving it towards the pupil towards the center line, but really we're going to have you looking at it as more pulling it up. And I say may have a slight difference because this is a great point to talk about. Your textbook, when you look at textbooks that are anatomy based, they will put and talk about this being moving medial. Some of your textbooks that deal with physical assessment pull and talk about them moving slightly the opposite direction in terms of abducting. I'm going to go with the anatomist on this one. So I jumped to team anatomist instead of the team physical assessment part because I think they probably spent more time actually figuring out what these do when they were dissecting the cadavers. All right, still innervated by cranial nerve 3. The inferior rectus muscle, bottom of the eye, inferior, it's going to pull the eye down or depress and it also moves it a little medially, cranial nerve 3. Your superior oblique, SO over here. This one is, it starts in the back of the eye, we'll see a little later, but it pulls around and goes through a little pulley system and attaches to the top of the eye, so that when you pull that this direction, when the muscle contracts this way, it actually pulls our eye out and it turns it down or depresses it. And this is the way it attaches. That part I'm not going to worry you about so much there. What you want you to remember is that the thing is known as the superior oblique, and it's innervated by cranial nerve 4, also known as the trochlear nerve. And the reason it gets the name trochlear nerve is because this little pulley that the superior oblique goes through is actually the trochlea. So they named the muscle that got innervated by cranial nerve 4 as the trochlear nerve. Now, how do I remember that one? Well, think about sulfate. You guys all went through chemistry class. Think SO4 for sulfate. Finally, our last one is the inferior oblique. It attaches indirectly in the inferior bottom side of the eye, and when we do it, it abducts the eye out, and it elevates it slightly. So each individual muscle, although they'll talk about it in the books, having different, realize that no muscle operates completely by itself. They all work to conjunction, and you have to have the two eyes moving together. So I don't necessarily want you to have memorized all that. If we're looking at the back, this will help you understand when we're talking about the superior rectus muscle, the superior rectus muscle there and inferior rectus muscle, how they attach the bottom, and then when you pull on them, they would pull the eye in that direction. Whereas if you look at the oblique, the superior oblique goes through the trochlea and it attaches in the back of the orbit, and so it'll pull it around. By pulling here, you actually cause the eye to want to kick out and look out that direction, and it also pulls the eyeball down a little at that point. The inferior oblique, because the way it attaches, same thing, only in a different area. It's going to make the eye look down and out. Don't worry so much about that, though. We want you to kind of think about the fact that these work together. You want them to be in concert. And so when we do a patient a physical assessment, we're going to ask them to make a big H, follow our hand while we make a big H, and look for signs of nystagmus. We're also going to ask them for any points where they become double vision, because when we see double vision start to happen, that means our eyes are no longer tracking together or at the same spot, focusing on the same spot. So again, don't worry so much about this one. This is just another way of looking at some of the different arrows, things like that. But I put these in there because you'll have, and this always gets folks a little confused, go with what I told you in terms of up and down and which ones we're going into team anatomy versus team physical assessment book. Now, this is what I really was getting at with the H, is imagine, and we'll show you this in class when we actually demonstrate the exam techniques. I'll ask the patient to I'll put my finger about a foot in front of them, or a pencil or pen or anything like that, and I'll ask them to keep their chin straight, and then I'll move it, follow my pen tip with the eyes, and just move that, and I'll move it out in a big H. So I'll move it horizontally to one side, then go up and do the H, then move it across again and back to the other side, make another half of the H, and then come back. And I'm looking for points where their eyes start to shake or jerk, and I'm also looking for any evidence of blurred vision. And with that, we'll finish up our talk.